Good evening and welcome to this live webinar with specialist periodontist Dr. Amit Patel. Routine dentistry has changed somewhat dramatically during the COVID-19 pandemic, with practices prioritising appointments based on the immediate needs of their patients. With the prospect of it being some time before dental services can fully return to normal, preventative oral care has never been so important to ensure patients' oral health is maintained. Therefore, the aims and learning objectives for this evening's session are to explore the important role of the oral microbiome in prevention and its role in host microbiome symbiosis. Dr. Patel will also explore practical ways to communicate whole mouth health with your patients within this current climate of dental care. If you do have any questions for Dr. Patel throughout the presentation, please do add them to the Q&A chat box on the right-hand side of your screen, and we will run a Q&A session at the end. Without further ado, I would therefore like to hand over to Dr. Amit Patel.
Thanks, Shelley. So I hope you've all had a good day today. I'm here in Birmingham in the United Kingdom, and today has been actually a good day. It's been the weather's been great. But I'm obviously here. This is me here trying to jump out of an aeroplane. So I'm the guy on the right because the guy on the left is a world champion, and he's flying far more stable than I am. And the cool thing about this photo is that there's a camera woman falling out of the sky, and then there's obviously myself and Doug, and then there's the plane, which I think is the coolest thing to see because you can see the whites of the pilot's eyes. Let's get this session. Yeah, so I did a bit of skydiving, and I've just got back into it, and I'm hoping to go next weekend and do another 10 jumps. I did a 13 a few weeks ago, which is good. Keeps me out of trouble, really. So, obviously, I'm going to be talking about how we can help our patients. You know, we've all gone through this lockdown in some form throughout the world. And here in the UK, it's been at least 3 months, and going back to work for most dentists, it's been a bit longer than that. So my lecture here, we're talking about how we can help our patients with regards to preventing their disease accelerating. And what kind of things we can do within our daily practice to help them focus and understand that actually it's all about them that's doing the hard work. Okay, so for me, I'm obviously a periodontist, and what I've learned over the last 20 years, when we were students, we sort of thought, the patient's got a filling or they've got an abscess, we need to just drill the filling out, put a filling in it, or the patient has this abscess and we're talking about extracting it. We were just very black and white in the way we do things. And perio was always a very difficult thing for me to completely grasp. And over the years, I sort of realized that it's actually all about the patient's hard work. And if we can get the foundations right with the patients, then they'll be able to have implants, any sort of restorations, whether they want veneers, smiles, or whatever. But I think most of us as students seem to focus on, and actually in patients, we focus on the teeth and how important they need to look and stuff like that, but the foundation is very, very important. So normally what I see on a regular basis, we see a house like this, we show that to be an implant bridge. But when we start looking under the guns, you see that the foundations are not ideal. Okay? So we know that periodontal disease is the most common disease, and if you look at the evidence, studies have shown, and studies shown by a guy called Bob Jenko, who's in the US, and they show that when you look at the population as a whole, at least 60% of the population will have some form of periodontitis. And I find that really interesting because when I lecture to many dentists, they'll always, not all, some will always put their hand up and say, we have no periodontal disease within our patient demographics, and that's just not true. When you look at the evidence, somewhat, within our group of patients, 50% will have some form of periodontal disease. And the other thing that's important is that Now we're seeing more and more implants in place within our practices, and our patients are coming in with implants down board, and there is a significant increase in peri-implantitis. So again, we need to be looking at those gum issues around implants as well. And within the UK, periodontal disease is a significant amount of cost, and £7.5 billion, maybe even more by now. It's quite a significant amount. And there are going to be changes ahead where we're going to look at how much treatment can a patient have based on if the periodontal condition is unstable, then what can justify do with regards to the rest of the treatment. And the most important thing for all of us dentists is that there is a high rate of litigation due to undiagnosed periodontitis. Now, I'm a medical legal expert, and I don't enjoy doing it. Don't do it much anymore because it was mind-numbingly boring. But I did learn from it. Right? What I learned from it was you have to write your notes really well. Okay, because essentially it's your word against the patient's word, and the patient will see an expert like myself, and they'll be able to look at the amount of disease that's present, and then also ascertain if the patient is doing all the cleaning that they were told by yourself. So really, the most important thing you should be doing on your notes is you need to be writing them well. So, for example, you should be giving oral hygiene instruction and demonstrating it. So that is what is accepted of an average dentist. And if you write that down, then you're going to be in a good situation. And then, we also see patients that, and when I was a proper dentist, and I don't do any dentistry anymore, I talk about oral hygiene and talk about the importance of cleaning their teeth and using instrumental brushes. But most of my patients would be saying, look, I'm here for a filling, and actually they were there for a checkup, but they were coming every 6 months to have some sort of filling done by the previous dentist, and I can see these fillings, right? So I think we have to be in a position where if you've got a patient who's not interested, then just make sure you've written your notes to say, look, you have a disease, and we can help you, but when you're ready, okay, it's important to cover yourself, and always say to a patient, we can refer you to the dental hospital or to the local, private periodontist, or send them to your own, your hygienist within your own practice. So you've got to just make sure that you've made the effort and the patient feels that something has been done. But always write notes down well. That's the most important thing. So what are the main characteristics of periodontal disease? I'm sure most of you, actually all of you will know it. Okay, so nothing has changed. It's still the same. On the left here, we have a healthy situation where we have a tooth in the periodontium, and we have root cementum, as you can see, periodontal ligament, and alveolar bone. Now, when we have disease, we then get destruction of the periodontal ligament, we get loss of crustal alveolar bone, and then apical migration of junction, which then forms the periodontal pocket. But the most important thing that we need to ascertain is all plaque-induced. Okay, so you have bacteria that's encroaching in the gingival margin, and something is happening within the patient's host response, and the body's saying, I don't like the situation, I am now going to extract the tooth. So that's the way I explain it to the patient. I always sort of say, look, you have this much bacteria around the tooth, and the body cannot deal with this, so the only way it can sort the situation out is by extracting the tooth. And I think that's much more powerful to say than to emphasize, cleaning as well, to talk about that they're going to lose a tooth if this disease is not under control. So if you look here on this slide, the warning signs that we all can see, we have inflammation, bleeding, infection, and you can see on this slide here, we've got inflammation of the papillae here, and I've obviously probed between the premolars, and you can see the bleeding on probing. And then you can also see sometimes, like for example, today I was doing some non-surgical therapy and root surface debridement, and as soon as I probed a pocket, pus is draining from that. So you will see pus also draining from that. And if you do see pus, there's multiple reasons why that could be occurring. There might be some sort of retentive factors that are underneath, so maybe a lot of subjects were calculus, and it's causing this inflammatory response. And then, there are also systemic reasons why the patient may have cholesterol in the pockets, and one of them is that they might have uncontrolled diabetes as well. So the other thing is we can take a long cone periapical, and in my mind, that's the best way to ascertain how much bone loss is present. Going back to my medical legal work, I would see a patient who has a bite wing, and if they have a bite wing, you see no bone present on the bite wing, and the BP scores for that, me being cynical, is always like a 1 or a 2, and that doesn't make sense. It doesn't equate. Okay, so if you don't see bone on the radiograph, you need to take a long cone periapical. In my practice, I take 6 periapicals mostly. I take a large one for the upper molar area and the lower molar. So I've got 4 on each side, longer periapicals, and I take either 1 or 2 in the anterior, and then 1 in the lower. And that's enough for me to know what's going on. And you can obviously take an OPG, but you need to supplement it with the anterior radiograph. And in my mind, I think it's far, far easier to just do the long cone. So here's a case that I've seen many years ago, well over 10 years ago. And she had this lovely bridge work done, but the problem was she was referred to me after it was done because there was some pocketing associated with these restorations. And you can see the upper left one, on the medial, there's only 3 millimeters pocketing, which is health. You can then see inflammation, and on the papillae of that pontic, you can see at least 6 millimeters. Now, one of the negatives about periodontal disease, actually there's 2 negatives, is that we don't improve the aesthetics. If you've already got bone loss, you do the periodontal therapy, and you will always get shrinkage of the tissue, and then you'll get sensitivity of the roots because the roots are exposed. So those are 2 negatives. And in this case, I had to tell the patient, listen, when we do the treatment, you'll have a gap between your anterior and the pontic of the lateral, and it's obviously not what she wanted. And and I showed her how to clean it, and I'll be able to get a grey incidental brush through that space. Now that's a significantly large incidental brush. So she never came back, and that's understandable. And I think it's really important as dentists, you need to be able to stabilize the disease before doing any cosmetic work. And what do they say? It's the same. You don't make excuses after the event. Tell them before that this is what could happen, and then we won't get into trouble. And I think it's always important that we try to do that. So here, you could restore it whichever way, maybe use some composite or whatever. There's other things you can do with this surgically to try to improve the soft tissue and make it look more natural. But, these things that we can discuss in the future. So going back to periodontal disease, it's all about having good foundations before you do the restorative or work. And I think this is the most important thing. So the essential tools we use here, especially in the United Kingdom, we have the BP probe, or the World Health Organization probe, and we know that's graduated. And I always use a Williams probe, and we know that's graduated millimeters. And then there's a neighborification probe, so you can ascertain what the depth of verification is, and then you can ascertain what the prognosis of the molar tooth is, depending on the treatment that we're going to do. So the basic periodontal examination. So we have the code 0, and here it says no bleeding or pocketing greater than 3 millimeters. Okay. Now I think that's not right when it says no treatment, because as dentists we give oral hygiene instructions and demonstrations. So if there's a code 0, we still have to give oral hygiene instructions and demonstrations, no matter what. It's our job. It doesn't take long to do, and I think it's important. When it's a code 1, bleeding and probing, you just give simple oral hygiene instructions. So if it's gingivitis, you can improve that relatively quickly within a few days. And if it's a code 3, they're part retentive factors. Okay, so we know that if it's a code 2, it's part retentive factors, and that lies between the silver band before the black line. Okay, so we must remember that with plaque retentive factors, we know with calculus, and we know that orthodontics is now becoming more popular, such as short-term orthodontics, and they wear kind of composite type of, I don't know what it is, but it's some sort of composite on the tooth for the tooth to move. So that's a plus. So you've got to make sure that's code 2 in your own examination. So when you have a code 3, that lies between the black band. So we have 3.5 millimeters and 5.5. And here you're looking at giving supragingival and subgingival scaling as well as the hygiene instructions. Now, in the last few years, we've changed the way we do a code 3. In the past, to get a code 3, you would have to do a 6-point pocket chart in that section. Now, you don't have to do that. You just give the hygiene instructions and do the non-surgical therapy. And you get the patient back in 3 months later when the soft tissue is matured and the collagen is matured to reattach to the tooth. And at that point, if there are no code 3s, you don't do a 6-point pocket chart. But if there is a code 3, you have to do a 6-point pocket chart. So it's far, far simpler now to just mark it as a code 3 and do the treatment. And the reason why they've done that is because if you think about it, the maximum depth of the code 3 is 5.5 millimeters. It's simple, isn't it? We know the maximum depth, so we can only know when it's improved, it's going to be less than that. And usually, a massive increase. Now, with the code 4, anything above 5.5, it's a full periodontal assessment, and we have to do a 6-point pocket chart. In my mind, I always do a 6-point pocket chart, medial, mid, distal of each tooth, and lingually or laterally. And recession is something that I don't do. I usually take photographs. And in most of my patients, if they've already got existing periodontal disease, that I write down the general recession. The only time I do chart recession is for medical legal cases, but also when I'm doing root coverage procedures for some of my patients that I do surgery for. We do bleeding score, clot scores, classification. Now, the classification, there's multiple classifications, but I use the old one by Amit Patel. Essentially, a class 1 is less than a third penetration and classification. A class 3 is through and through, and a class 2 is everything in between. To keep things simple. Mobility of the teeth, again, we use the Miller classification there, and grade 3 is the most easiest for me because it's a vertical movement. Grade 1 is about 1 millimeter, and grade 2 is greater than 1 millimeter. And sometimes I do get grade 1 and 2 can change, which is very, very subjective. It's a bit challenging for me, to be honest. And I always take radiographs, like I told you earlier. Long-term verification, I do for now. I don't do lots and lots because it's challenging for a patient to have multiple plates being put in and kind of get the whole mouth. I mean, when I worked at the university, we'd take a lot of radiographs, and I can see why. But for me, it's really important to get to the crux of the examination, really, and get on with the oral hygiene instructions. So we know that the etiology in everything in dentistry, the etiology is bacterial cause. So the primary cause is bacteria. And a lot of their studies have been based on periodontology. And now more and more, when you think about it, in the past, when I was a student in '92, we would have to remove all the caries, make sure the cavity was really, really clean and sparkling white. But things have changed in time, and we know that if you reduce the amount of bacteria in that cavity, then the body will try to repair itself by laying secondary or tertiary dentine. And you don't have to remove so much tooth structure. So it's really, things have definitely changed. And perio was always that way. We always understood that if you had too much bacteria in your mouth, it had an effect on the way the disease would progress. Right? So by reducing the amount of bacteria in the patient's mouth, we can then change the outcomes and the way the body is responding. So it's all a fine balance between what is happening with the host and the bacterial population. And it's the same when you think about endodontic lesions. I mean, we can see some really terrible root canal treatments, right? And yet the lesion at the apex feels beautiful, and you can see some beautiful root canal treatments, and the lesion still does not heal. And for whatever reason, if you're cleaning out the canal and you reduce the bacterial insult within the apex, and the body will try to repair itself. So it's all, for me, really quite fascinating, how how it's changed. And it's not, it's not all woodwork anymore. So there's much more thought process about the biology and the interaction to the all microbiome. So as I sort of said, we look at, we know that bacteria has a massive impact on a lot of the diseases of mouth. And when it comes to perio, we know that the end goal, as I said earlier, is that the patient is trying to extract, the host, the patient themselves, even though they're not trying to, is trying to extract too. And the whole COVID situation has made things really quite complicated. So I've been at work since, I didn't come back to work on June the 8th, and I never bothered. I just wasn't interested in starting in June. I wanted to start back in July, so I took the time. And I have seen some of my periodontal assessment patients and my periodontal review patients that I haven't seen for months now. So normally I see them every 6 months or a year, but some of them are even longer. And what's been really interesting about my patients is that their oral hygiene has been really, really good. And there's very little calculus around. So I think if you can impart the right information with your patient, then they will just do it. And that's what I love about, being a periodontist. So it becomes the patient's own problem, and then they'll deal with it. Now, I have seen one patient, and his periodontal condition has deteriorated. Now, what was fascinating about that is he runs a company, and it was a stress that had a massive part on it. And we know that when you look at the evidence, stress impacts your immune response. And if you think about it, periodontal disease is all about the immune response. So, and we know that stress can affect the way the neutrophils function, and as a consequence, his periodontal condition started to become much more active. And we had a few more pockets. But that was interesting to see the difference. It is fascinating when you see the whole link between external factors as well as what the patient can do. And if you think about it now, the NHS has an idea, a plan in which way they're going to get back to work, and it's going to take some time. I mean, here in Birmingham, significant NHS presence of dentists, and I was speaking to some NHS dentists for the weekend, and they're working at 10% of their normal capacity. So there's definitely work out there, and we get phone calls now saying, please, do you clean teeth and this and the other, and we can do that. But obviously, we're under restrictions and the way we do things. We wear full FFP3 masks, and we wear gowns, and then we have our travel time, and it's a little bit more complicated. But as long as you plan it, it can be done. But I'm not sure when things will get back to normal. I think, I'd like to hope, for Christmas, we start getting NHS centres working back to normal, because I'm a referral practice, and obviously, my business is reliant on them referring, so it would be really helpful, but I have to also change my business model, and I'm looking at doing that in the very near future. So, and I've touched on this, looking at the challenges of the microbiome and the whole mouth health, and the importance of, the control of the bacteria within the mouth. We touched on that earlier. So, there was an article in Time magazine some years ago, and essentially it talked about inflammation. And this is the most important thing. And when you think about it, for example, a patient can be significantly obese, and their body has far more inflammation within their systemic system. And if a patient has stress, again, their inflammation increases. There's so many factors that lead to inflammation. And we know that if you have cancer, again, there's an increase in inflammation in your body. All these things, all a matter of reducing that inflammation. as a consequence, it has less of a systemic effect to your host. So, I mean, I went to an amazing lecture some years ago, and you can take high-dose vitamin D. So a lot of my patients are now taking high-dose vitamin D, and that's one of the reasons for that. It helps reduce the amount of inflammation in the body. And you know, and I do dental implants on my patients, and my patients average from about 30 till about 90. I do implants on these patients and do periodic treatment as long as they're healthy. And all my patients are now taking vitamin D. And there's no harm, and we know that it helps reduce inflammation. So we've got to think about the whole body. So here we have the patient, and we've got to assess the risk that they're under. And the word that's been floated around is microbial dysbiosis. Okay, so now that essentially means the amount of bacteria that you have and the bacterial insult to the host. And as a consequence, you then get a hyper-inflammatory host response. So when it comes to trying to explain this to the patients, I talk about CSIR. We have a CSIR. And say, well, you're on this side, and we would like everything to be even, and on this side we have bacteria. Okay? Right now, at this point in time, we have too much bacteria, and your body, your host, you can't deal with it. So your body inflicts that too. So if we can get you to clean significantly better and reduce the host response, then you'll be able to keep the teeth for many years to come. So it's all a matter of talking about this fine balance. And I think, as a student, one of the few things, we'd always talk technical terms, and I don't like talking about that because you want to win the patient over. And the more simple you can make it sound, the better. And let's see if you've got patients that are scientists and they want to know the technicalities, you can then follow the words in and they'll understand it. The majority of patients just want to know if you can help them. So again, if you look at this slide, we're talking about the host, and then on the left and on the right, we've got the microbiome, which is obviously the bacteria inside the patient. And we're trying to find an homeostasis, and that is a matter of reducing the host, reducing the host response by reducing the amount of bacteria. And there are loads of external factors I touched on earlier, and we know that. So for example, most of my patients are smokers, so we know that smokers are at increased risk of periodontal disease. And sometimes you may ask, I remember when I was a student, and you read a book that said, well, the reason why smokers have periodontal disease is because they were seen as dirty. And I love that. We don't really. But we know now that essentially smoking affects the neutrophil function, and the neutrophil is the most important cell in immunity in the gingival curve. Okay? So there's a lot of studies out there showing that if you smoke, you increase your risk of losing your teeth by a factor of 3. And that's quite significant. Now, if you've got genetics against you and you've got like progressive periodontitis, then you get the risk factor of losing teeth by a factor of 5. That's a lot. Okay? And when I talk to my patients about this, I just throw the ball back into the court. And if they bring it back, I will keep just throwing the ball back in the court because it's their responsibility. I can't do it for them. I tell them, I give them another bit of information, which is really, for me, quite powerful. So, for example, I say to them, people who smoke, right, have an increased risk of dying of something that's smoking related by 50%. That's quite massive, right? So I say to them, if you knew you're going to get in your car and come to see me, and you had a 50% chance of dying, would you have gone in your car? The answer to that is no, right? But we're happy to smoke, okay? So what I do with my patients is I just say, look, I'm not your mum or your dad or whatever, and I'm just going to say this once, and that's it, and I will still help you, okay? And then it's their choice to give it up, okay? And again, I touched on stress. Stress can also reduce the immune response. We know that with lots of evidence. Yeah. So there's lots of external factors which you can't control, but the thing that we can control really is getting the patient to be more efficient and effective. So we know that there's a lot of bacteria in the mouth, and we know not all of it is bad. We know that there are gram-positive and gram-negative. Obviously, gram-positive are the good ones, and gram-negative are the ones that are obviously more ideal. Okay, and when you look at look at this slide here, we know that most of the bacteria is around the gingival tissue, as well as the protein. And then now more and more, we're also keen on trying to get patients to use tongue scrapers because we know that's a significant area where there's bacteria that can fit. That doesn't cause periodontal issues, but obviously can cause halitosis. And we know there's lots more evidence coming out that we should be trying to reduce the bacterial load within the patient's mouth by using tongue scrapers and give the patient clean more efficiently and effectively, and also utilizing the right kind of toothpaste that will reduce that insult. So ultimately, like I said to you before, you can help the patient reduce the bacterial burden in the patient's mouth and the reservoirs, like it says on the slide. You may use some sort of mouthwash as well, but we know that when we look at mouthwashes, they only penetrate a millimeter of the gum. So if you've got a pocket of 6 millimeters, it's never going to get in there. So the most important thing for that is by using the right size instrument brushes to scenarios. So I touched on this about the slide, I'll skip that, about the seesaw. So going back to the etiology, we know that there are also many factors that can influence the nature of the disease. So we have local factors, such as plaque traps and lack of saliva. And when you think about it, with a lack of saliva, if the patient has incompetent lips and mouth breathers, you have the saliva always drying up, and saliva is very important because it has also a washing effect. It's always reducing the amount of bacteria in the mouth automatically by washing it away. So here we have a patient that I've seen some years ago, and I like this slide because the thing is about this is the patient actually is cleaning their teeth really well, and you can see that the teeth look really clean. The only place where they're not clean is when it's on the root surface and going to the gingival margin. And it's really difficult sometimes, just because we clean our teeth relatively well, supposedly, it's sometimes difficult to sometimes grasp why a patient can't do this. And in this scenario, the patient just felt that if her gums bled, it was a bad thing. You see? So she never touched the gum line, and as a consequence, the plaque built up, the plaque stayed, and then as a consequence from that, calculus. Now, one of the things you've always got to remember in this case, if you're going to scale these teeth, you need to throw your excuses in first, because what's going to happen in the lower teeth, the calculus is connecting all those lower anterior teeth. The teeth will become loose. So never tell them after the event. So once you remove all this calculus or the scale, it's like removing the cement from between the bricks. The bricks are going to get loose. Okay? And this is a patient I tried to help, but she couldn't get over the idea that bleeding was a normal thing while the tissues are healing. So it's a shame. And we know there are systemic factors that can also modify the host system. And we know that because if you think about it, we have patients who have hormonal problems or drug-induced, they're on medication, such as phenytoin, which is an anti-epileptic, and we've got patients who are on calcium channel blockers, again, that's an antihypertensive, and we've got patients who are on cyclosporine, which is an immunosuppressant medication. And all these drugs can affect the way the fibroblasts work. So, for example, if you're on cyclosporine and that's affecting your fibroblasts in a particular way it functions, and if you've got bacteria and plaque forming around the gum line, then you're going to get gingival overgrowth for that reason. You've got patients who might have diabetes, and we know that if you're diabetic, it also affects the way your neutrophils function. And what's interesting about the diabetes is we know that if the patient improves their diabetic control, their periodontal disease improves. But we also know that the patient improves their oral hygiene, their diabetic control improves. So there's a really good link between the two. And so when I see a patient who's got diabetes, I will say to them, how well controlled is diabetes? And they'll say, oh, it's really bad or whatever. And then I'll say, I can't turn around and say, look, you need to change diet, stop eating alcohol, sort of stuff, because they know these things. So I can sort of spin it and say, listen, the good news is, if you were to clean your teeth much better, your diabetic control will improve. And they sort of think, oh, that's another way they can do it. Do you know what I mean? So it just makes, got to find a different way of attacking the problem. That's what I do. Seems to work. So we know that when we look at periodontal disease, and it's really unusual in the sense that you might have a lower 6 and there's severe pocketing around that, but the 5 may not have any issues. So we don't know why it's so site specific. Is it to do with genetics, or is it to do with the anatomy of the roots, or whatever? But it is fascinating, and even though there's no, if there's a presence of inflammation, doesn't mean that there's active disease progression. But in my mind, if there is bleeding on probing, I will always use that as a way for the patient to be more motivated to clean the teeth. So I get patients coming back to me saying, "Oh, this tooth bleeds a bit," and I'm like, "That's really good," because they're so attuned to what I want them to do. And I think actually you're doing a great job, and this is where we should take things to make them improve. So I think it's really important to know when we're treating periodontal patients that we need to build some sort of relationship, because the thing is that going back to university, most of us treated them and it felt like nothing improved, right? And even when we work in normal general practice, you get patients who do this best and it's like nothing gets better, and then, but it is all a matter of getting the right kind of patient. I'm in a very fortunate position because a dentist will refer me a patient, and they've already filtered out the patients that don't want to do it. But the ones that do are already keen to improve things. So I'm in a lucky position, and I can understand why sometimes it's challenging in normal practice or at university. And I think it's challenging. I don't know. I mean, one of the things I think is really important to do when you've got patients that are very difficult to treat, the hard ones, the ones that are not interested. The most important thing, if their plaque scores are greater than 20%, we are not supposed to do non-surgical therapy because there's evidence to show that will accelerate the disease. Okay, this is based on the data. And so 20% is not a lot. We think about it. We're almost looking at just under a quarter of the mouth. Get the patient to clean 3/4 of the mouth that we can do non-surgical therapy is not that hard. So if the patient is not motivated or ready to do that, then the way to do it is you write a note saying plaque scores are greater than 20%, and it's really important to emphasize the patient, look, we need them to be a little bit better. Right now, all we do is we're treating a palliative one. I think the word palliative is important because that almost sounds like we're treating someone with cancer, and essentially this is as much as we can do for you before all goes wrong. Okay. And say, look, we can only clean above the teeth for you, but we can always help you when you're ready. So always write notes down in that way. So if the plaque scores are greater than 20%, just give them all hygiene instructions and do a scan. That's the way I would do it. If I worked at dental school, I would be discharging patients if their plaque scores were never reduced to some of that we could done, because essentially we need to be treating the patients who want to be treated. And we know that when we look at the pathogens that involve periodontal disease, there's well over 600 now, but there are 4 main causes, and that hasn't changed in many years since I was a student. So we have AA, and we have PG, we have Patel intermediate, and we've got Bruce Forsyth. Okay, that's where I remember it. But essentially, AA used to be Actinobacillus actinomyces concomitans. But about 10, 15 years ago, they realized that the Actinobacillus was the wrong type, and would be in the Agaricotobacter family. At least we know that it's AA. That's what it's simple. So this is the classification done by Armitage back in '99, and I like this classification. It was simple. But you all know that the new classification has come about approximately 2 years ago. American Association of Periodontology and the European Federation of Perio got together and they discussed how the evidence has showed that the disease is not as we thought. So they've removed the word aggressive periodontitis, they've removed chronic, so it is periodontitis. And one of the important things from the classification is gingivitis. Okay, so we've never been able to classify gingivitis or in a succinct way, and they have now. So all this is very wordy, but essentially the most important thing is that we know that if there's less than 10% bleeding sites and no probing depths of greater than 4 millimeters, then we have periodontal stability. Anything and greater than 10% bleeding sites, then we get gingivitis. And I think this is that sort of helps us classify gingivitis quite well. We never did that before. The goal of periodontal therapy for me is to arrest the progression of the disease and prevent any further tooth loss. Okay. So what do? We have initial non-surgical therapy, which involves extracting teeth for prognosis. So if you've got teeth that are grade 3 mobile, I think they have to come out. But if a patient has seen me, they don't know me very well, they will keep their grade 3 mobile teeth for about 18 months before they've built trust with me, and then they're able to take it out. I think if you're their dentist and they know you well, take out those teeth because they're not good, and they're reservoirs of bacteria and stuff. Improving the patient's oral hygiene. And in my mind, if you've got periodontal disease, the only way you can clean between the teeth is in-center brushes. And you look at the evidence, again, brought out by the European Federation of Periodontists from 2 years ago, they showed that in-center cleaning really should be done with for periodontal disease. And if you can't get in-center brushing, you can use a little bit of plastic one. And then if you can't do that, then flossing is a lot easier. Because what we know now is that people can't floss. They're not doing it efficiently. And then we're looking at supergingival scaling and non-surgical therapy, meaning root surface debridement, using ultrasonics and hand instruments. Now, this is more complicated now with COVID, but I am using ultrasonics, like I said before, with FFP2 mask, with the waterproof gown. That becomes quite hot and challenging to do, but within my practice, when we're doing we would normally do half a mouth one day, another half a week later. Now we're booking off the patient to be the last patient of the day, and we put 2 hours and do the whole mouth in one day. So bilateral IV blocks, full mouth infiltrations, and patients seem to get quite good with that. And then we can have the palatal left while we do this. So I also use hand instruments as well, because periodontist, I need to feel like I'm a specialist, and I'll use a hand instrument. And we use the Gracie curettes by U3. They really are the best. And the Gracie curettes have been designed for specific teeth. And one of the things that I only use 4 instruments. I use an anterior one, I use a premolar one, and then I use a medial molar and a distal molar. And I try to keep things simple. So I use ultrasonics, nice big chunky one to remove the supergingival calculus. And then I'll use a fine ultrasonic to go down deeper, and then I'll use my curette to make sure the root is smooth. And that, for me, gives me the results I want. So, like I said earlier, we do a periodontal reassessment at 3 months, and the reason why we do that, it takes about 6 to 8 weeks for the collagen to mature, and to leave it for 3 months, you really get good attachment. And then we do a new pocket chart then. In the majority of cases, things have improved significantly. You might get the odd pocket around some of the molar teeth, dislocation involvement. If the patient is periodontally stable, then they put onto a maintenance regime with either you or your hygienist, maybe seeing you or the hygienist every 3 to 4 months. And then as things improve, you can, as things stabilize, you can then, in my hands, I see the patient for 6 months, maybe a year, but they're always seeing a hygienist every 3 to 4 months. If they're periodontally not stable, then you're looking at doing another course of initial non-surgical therapy and maybe an adjunct. Okay? So, such as some sort of chlorhexidine-based gel or some sort of antimicrobial that's going to local. I wouldn't suggest you use systemic antimicrobials. I would only suggest you use systemic antimicrobials as a first resort, but only in aggressive patients who are young, don't have much plaque around, and severe disease mostly around the anterior, as well as the moles. And we all know that the mole and if things can't be, if things are very localized, then we're looking at doing surgery. And now, more and more, we try to regenerate the bone that's missing. We bovine bone and enamel matrix proteins work really well. In the past, we would do a lot more dissection of tissues, so we expose more and more to them, and that still has a role, especially in severe disease. But more and more, we're looking at trying to regenerate the bone that's missing around the So I have this kind of flow diagram. In my practice, I see a new patient, and if they, I show them how they clean the teeth, and that so I have an hour conversation. And in that hour, I will spend maybe 20 minutes, 30 minutes showing them how to clean the teeth more efficiently with an electric toothbrush, and showing them how to use them for brushes. And if they do it and don't complain about the bleeding or sore or any negative, then I will take them down the left path, and I will do the non-surgical therapy all in one day or within 24 hours. So this is obviously pre-COVID. And that's known as the full mouth disinfection protocol. And there's a professor called Philip Preshaw. He used to be at Newcastle, really lovely man. He's moved over to Hong Kong now, I think Hong Kong. I'm not sure. And he's done lots of studies showing that if you can do all the therapy within 24 hours, you're going to get significant improvement. Now, if you have a patient who says, well, it bleeds and it hurts, and I don't, and so then we go back to the traditional way where we do non-surgical therapy in each quadrant over 4 visits. And there's nothing wrong with these 2 treatment plans, okay? Because essentially just reinforcing the patient's oral hygiene. The only advantage of going down the light blue path is that you get quicker results in a short space of time. On the right side, it takes longer. But the most important thing with both of these is that in the long run, you get the same result. Now, for me, I want the patient to understand that they have a disease that needs to be treated, not to think, oh, just clean your teeth. I use the word, we're going to be now removing the bacteria that are in the gums, so we can improve the health of the tissues and stabilize the disease. We're going to not just use the word, we're going to clean the teeth, because within the UK, we've just devalued ourselves with the public, really. And I think the public needs to understand that we're highly trained clinicians, we're therapists, we're hygienists, we're all very, very highly trained clinicians, and we need to be able to make them aware that this is what we can do for you, and not just cleaning the teeth. And now more and more we know with the evidence of everything being linked. So I have a patient comes in and he might be overweight and he's had a heart attack, and I will say to them, so there is a link that the bacteria in the mouth can also affect your heart, your vessels and stuff, and that makes makes them think differently about the whole situation. There's no harm in telling them these facts. I think it's important. So the long-term success of treatment, really, the key to success really is motivating our patients. And that's what I do. So in my mind, if you empower our patients, they will make the difference. Let me give you an example. So my mum's a smoker. I smoked from the age of 14, and she used to stick out and stuff like this. And she's 74, and she stopped smoking 10 years ago. And it's interesting, I've treated her periodontal disease, and I get to use the biggest incidental brush in the tooth. But does she do it? The answer is no. Right? Now that's my mum who can't grasp that her son is telling her what you have to do. And her excuse is, my dentist says I don't have to use them anymore. I know her dentist, and I know she's lying to me. Right? So it's really difficult sometimes to treat our patients, and the more knowledge you give them, they will make a difference, like you said. And so in my practice, if I come across as enthusiastic and positive to my patients, then you'll win them over. So they'll always come in and say, oh, my gums are terrible, or my diet's this and that. And I will always try to find something positive in the mouth. Oh, look around. Like I saw a patient today, she's 76, and she's been referred for periodontal disease. And actually, her teeth are really good. And I thought, actually, her teeth are really beautiful. And that sort of wins the patient over, doesn't it? I mean, it's not like lying, But I think you need to build rapport with the patient. And like I said, and sounding enthusiastic, and I say, we have many patients like you, and they come in and saying the same things. But we can help them, and things can improve. And they're happy with the results we achieve. And I think the other thing you say is that I always do 30% of the work. I always exaggerate 30% of the work, and then I say you do 70% of the work. And the more you sort of emphasize how important it is for them to do it, they sort of figure it out. And again, like I said before, the good news, you always say to patients, the good news is that we can help. That's what they want to hear. And I think as a student, and even after I qualified, I never understood that because no one taught me that. And there's a lot of cosmetic dentists out there, patients saying, I really want my teeth to look perfect. And we can always talk about negatives. If you can say to them, actually, we can help you. And then you say to them, well, look, you actually have some other issues and we need to resolve that first. They know that we can help them. That's the most important thing. And the other thing I heard from a really good hygienist that I used to work for in Manchester, Maggie Jackson, who's an exceptional woman, I learned almost everything from her about career, is, my job is to give you the power and the knowledge to treat your own disease. And that's the most important thing, and not to rely on me. And I will say to them, if I was hit by a bus tomorrow when I was jumping out of the gym, hurt myself badly, you've got the tools to do it all yourself. And that's the most important thing. I always avoid dental jargon, like I said before. Use words that are far more emotive. And I use words that are far more emotive. So, for example, I don't use the word plaque at all. Plaque is a word that means nothing. If you use the word bacteria, that's far more powerful. So if you think about it, when I was a kid, there was an advert for domestic. It kills 99.9% of all germs in the house. So my parents would buy the stuff and use it, and now everybody's got allergies because they're not eating the lot on the ground and stuff. So if you use words like bacteria, it's far more emotive. So you have bacteria in the mouth and you need to reduce it. I think those words are more powerful than using words we've got plaque and build up and this and the other. It means nothing to the patient. When we look at the evidence again, electric versus manual, in my mind, every patient should use an electric toothbrush. When you look at the systematic reviews by Worthington, they show that if using oscillating rotating toothbrush, far more effective at reducing bacteria. And in my mind, there are apps also with these toothbrushes which then get a patient to be motivated to do more. If you think about it, how many of your patients own Fitbits? They use these Fitbits, do the steps, and they want to beat themselves. And these apps are now designed so that the patient can beat themselves every day and do better. And I think these little things, even though some of us, I never thought about using them. I thought they were wasting my time, but I can see now the benefits. And now when I use it, it's you sort of think, okay, I can do better. So I think these things can help improve and motivate patients and help them reduce bacteria in the mouth and just look at the whole situation. And here, this is a study done by Bearhouse, really old study. He showed that if you use a large dental brush efficiently and effectively, it will reduce the proton depth by 1.5 millimeters. Now, if you think about it, the code 3, BPV code 3, the maximum pocket depth is 5.5. Now, 5.5 minus 1.5 is 4 millimeters. And remember, 4 millimeters is seen as stability. Now, this is why code 3 can reduce significantly to health if they use the right size brushes. And the same study done by Verhan shows that if you use the right size brush, you will penetrate a pocket of 2.5 millimeters. If you've got an odd couple of 5 millimeter pockets, you will still be able to maintain that with a large internal brush. This is an old study. This is the secret for all periodontists. It's a matter of getting the patient to use these brushes. And then the patient does all the hard work. It's really easy if you're the right motivated patient. So here, patient I've seen years ago, quite young. You can see we've got severe pocketing on the lower right side and inflammation. Essentially, what happens with these kind of patients is the in this case, this patient came back a week later with reduced pneumonia. I think it's really important that we use the right size brushes. In this case, the patient was using yellow and brushes, and now he's using grey ones. Inflammation is reduced, tissues have become healthier, and the patient's ready to take the montage prepared. So, going back to now, back to work, post-lockdown, post-COVID, what do we do now? That's the question. And I think it is, like I said, you have to empower the patient. If you can empower the patient with all of the tools, using an electric toothbrush, using the right sort of toothpaste and mouthwashes, all these sort of things, it will just empower them so that they know whether reducing the bacteria inside, and then full back control on the biofilm. Okay? So here, we go to the European Federation of Perio website and pull the articles here, but they've come out with a consensus statement saying that we know that fluoride is very, very important. We've known that it's always been important to reduce the amount of caries within the population. But we also know now that we should have some sort of an antibacterial chemical adjunct within it to help also kill the bacteria that's in the mouth. So the companies have developed toothpaste to do this as well. So we have the toothpaste here, Colgate Total, and we know that's been around for years. And they've been able to now link it up with an antibacterial, which is have an activity within the antibacterial. And if you look at the fluoroscopy information here, you can see that when the toothpaste is put onto a plate with bacteria, it also reduces the amount of bacteria load in that side on the plate. So, I think one of the other things we should be looking at doing here, if we look at this, we should be getting the patient to, scrape the tongue, because that's another huge reservoir of bacteria, and we should be looking at getting the patient to use the right space between around the gingival margins and in between the teeth, which is where we're hiding. Okay. So the goal and prevention for, the reality is, if you think about it, the main aim is to get the patient to clean their teeth well. And, I have patients who come back after maybe they've been for consultation, they come back a week later and they say, my teeth have never felt clean. And they were saying, what's interesting, I wish someone had just showed me how to use these tools efficiently and effectively, so then they could have kept things, the status quo as in a healthy situation. So it's all a matter of trying to give them all the information, but not to bombard them and just do it step by step. So what I do with my patients is, we get patients who use interface brushes and then they're doing this and that, and they come with a whole bag of stuff, and I just say, look, right now I want you to just brush this way. I want you to use brushes, and I want you to use this toothpaste. And so, for example, a lot of my patients have sensitivity. Every one of my patients is going to have sensitivity. And one of the things is, because when you do the treatment, the roots are exposed, but you need to be using a toothpaste which has that sensitive base, sensitive action to it. So I get my patients to code release, and one of the reasons why I don't use that is it works so quickly. And so going back to my mum, I treated her periodontal disease, and it took her 6 to 9 months before she could have her spoon. But these things you've got to keep doing in between the teeth with that toothpaste on an incidental brush, because you lay it on and don't wash it off. Never rinse the toothpaste out because it has an effect. I think all these little things we have to tell our patients. And I think I read this quote by Stephen Hawkins, and I think this is really quite apt in this day and time. Like today, I had a really lovely woman, and I've done some implants for, and she's 76, and she's not done well through COVID, and her mental state has sort of gone awry, and she needs to come in and just speak to me. And she was like, I'm too embarrassed to show you my mouth. And she goes, everything is rotten. I was quite distressed because I wanted to help her, but I couldn't, and she's now in care, and everything was just going wrong. And I think, and anyway, so I reassured and I tried to, that she, I think there's some sort of memory loss going on as well. But I think we need to be showing some sort of empathy for our patients through all the difficulty they've gone through. And I mean, obviously we have too, but it's important to listen to them. I mean, the other day I met another patient and he quit his job to start a new business, and it was like we needed to hear, the trouble that he's going through. And another patient is a mental health nurse, and she came in because she was worried about her implant, and there was nothing wrong with the implant. But then she wanted to talk to me, and it was a matter of listening to her saying, she says, I see these patients coming into the hospital, and I'm making the right decision by not sectioning them. Will they still be alive? And she was saying to me, and she cries every night, and she goes, that was really distressing to me. So I think we need to show some sort of empathy to our patients. Hopefully they'll show the same thing back to us, because it has been really quite bad. I mean, now, especially when the way things are going to go in the future, we don't show what's going to happen. So I think that's important. So thanks for listening. And if anybody's got any questions, you can always email me later on. If I can get my email to work, this is just one. Thanks for listening.
Great stuff. Thank you, Amit. You're noting that periodontal health is dependent on the balance between the host and the bacterial population. It's fundamental intervention. I think that was really key and came through nicely in the presentation. Empowering your patients to take control of their oral biofilm, that was something that you highlighted as well, and to achieve whole mouth health, the focus of proactive prevention today. And just by making some simple changes, something as simple as changing your toothpaste, as Amit mentioned, Colgate Total provides that superior biofilm control. Now, to support this idea of proactive prevention, I'm going to take you on to the next slide.
There we go.
There we go. Yes, so to support this idea of proactive prevention.
This is really good resource. I've had a look at it. It's really, really good.
Yes, thank you, Amit. So Colgate have developed a series of educational infographics and videos for you to be able to share with your patients. And the idea is to help educate, motivate, and keep oral health top of mind. These resources are really designed so that you can share via social media, direct email to your patient, you can upload them to your practice websites, and even use them in surgery via a tablet or computer. Or if you have sort of patients that prefer that hard copy, you can print them off for them to take home as well. So there is a link on the screen. These resources can be found by following that link, so the www.colgateCommunication.co.uk/educational-resources/#. So before we do close tonight's webinar, I will just open up the Q&A session. I know we're quite limited for time, but I don't think too many questions have come through. So just bear with me. No, I don't actually think we have any questions. So unless anyone
that's a shame.
That is a shame. So unless anyone wants to pop anything on the Q&A chat box now, if not, Amit, that's a good sign that you've covered everything in the learning objectives, I believe.
And to be honest, if anybody wants to email me directly about any questions, I'm happy to always answer your questions. It's not a problem. I'll do my best.
Okay, I'll just wait a moment or two just to see if anything comes through. But if not, I hope that you all found the webinar by Amit very interesting and useful. And please do take a look at our infographics and video resources, which you can use with your patients. So if there are no further questions, pardon?
I think they're really good. They're really good.
Okay.
I think Nick, you've done it.
Good stuff. Okay, well, it looks like there's no questions. So thank you to everyone that has joined this evening. Thank you again to Amit. And we hope to touch base with you soon. So take care. Good night.
Have a good evening. Bye-bye.
Bye.